Hello, I'm Deborah Sims. I'm a CLL patient reporting from the American Society of Haematology for Leukaemia Care UK.
I'm Susan O'Brien from the University of California in Irvine, the Chow Family Comprehensive Cancer Center.
Susan, it's been an amazing day here, first day of the conference. It's been a very CLL heavy day. I've run from session to session with my head sort of progressively blowing up. The data's just been incredible. So much has changed in such a short period of time.
It really has. Now we have not only novel agents in terms of targeted small molecule therapy as opposed to chemo, but now we're starting to see combinations of targeted therapy which are producing some very exciting results.
For the treatment-naïve cohort, patients who are now facing treatment, the time to treatment hasn't changed, so the guidelines are still that we do watch and wait until data tells us otherwise. But the treatments that are being available in clinical trials and the data that's coming out from them, it's quite outstanding, some of it.
It's really impressive. We heard a presentation from MD Anderson about using Ibrutinib and venetoclax, so the BTK inhibitor and the BCL2 inhibitor, both oral agents, in combination for frontline patients who are high risk. So high risk was generally unmutated IGHV status or 17p deletion or p53 mutation or 11q deletion. So a higher risk population. And using these combined two drugs for a finite period of time, they have not only very high response rates, but very high levels of MRD undetectability. And that's very exciting because that means that those are very deep remissions. And we know, in general, the deeper the remission, the more durable it's going to be.
And even in my time over the past couple of years coming to conferences such as this, MRD wasn't being discussed as an end game 2 years ago, and now everything, and they're actually talking about levels of MRD in a lot of these sessions.
You're absolutely right, because of course you only talk about something as an endpoint when you can actually achieve it. So now we are seeing combinations where we're able to achieve that level of negativity, and as you said, now we're even looking at deeper levels. So the standard of care in trials for calling patients MRD undetectable has generally been in 1 in 10 to the 4th cells. Now we're even starting to have assays where we can look at deeper remissions potentially, so 1 in 10 to the 5th, 1 in 10 to the 6th cells, and some of the regimens are actually producing MRD levels that low. And again, that is just so exciting. As you said, to go from regimens where we weren't even talking about getting to that level to now getting a lot of patients to that level or even deeper, so exciting.
And is there still going to be a role for FCR and BR and chemoimmunotherapy in a certain subset of patients, or because of the impressive results of these novel therapies, do you think there'll be an increasing move when we have access to them in countries like the UK and other countries that don't have the treatments we have here? Will that become standard therapy and chemoimmunotherapy won't exist anymore?
Yeah, there's 2 important presentations here comparing in one bendamustine rituximab to ibrutinib-based therapy, or in the other comparing FCR, kind of the gold standard of chemoimmunotherapy, to ibrutinib. And both of those trials showed that ibrutinib produced better progression-free survival, meaning the remissions were lasting longer with ibrutinib than either of those chemotherapies. So there's no question that chemotherapies, when you have access, as you said, are going to start to fade away.
One thing that stood out for me, one of the presentations this morning, was that actually in the older untreated cohort, over 65 patients, actually ibrutinib as monotherapy was almost preferable to adding in rituximab, which surprised me.
It kind of, I think in the initial findings surprised everybody, and the reason it surprised everybody is we know from chemotherapy that when you add in rituximab to any chemotherapy, and not just in CLL, but other lymphoid malignancies like lymphoma, acute lymphocytic leukemia, we know that without exception, you do better than just giving chemotherapy alone. So the question was, is that paradigm going to continue with the small molecule therapies? And it may vary by small molecule too, but you're correct, there's now 2 randomized trials comparing ibrutinib to ibrutinib rituximab. We do know that one potential advantage of adding rituximab is that you get a much more rapid response because the lymphocytosis comes down more quickly. But the real question is, does it make the remissions last longer? And both trials now have shown that the remissions do not last longer. Giving the rituximab, it's the same results as with single-agent Ibrutinib.
Fantastic. Well, I'm looking forward to day 2 and 3 and 4 of this conference. Thank you so much for your time.
Pleasure.
Thank you.